summarize just a high-level take-home message, I heard a lot of systems and integration and macro and big company, big Hill and your 5,000 physicians. It's interesting in a value-based care discussion. In this whole conversation, I never heard anybody mention precision medicine. Is that below the level of stuff that you folks are looking at, or is that a futuristic, or is precision medicine not factor into the value-based care paradigm?
Yeah. Go ahead.
It's a different event, is what I'm hearing. But no, precision medicine is absolutely part of the picture. I would say from a value-based contract and construct, it's still looking at these really big domains. Quality, utilization, total cost of care, patient experience. But, we believe there is a lot to be done in precision medicine. So there's pieces of it where we're gonna invest in as a technology platform to support and enable precision medicine and where within the workflow. But it hasn't really made its way up, I would say, from a contractual relationship across stakeholders of the system.
And I think the missing link over there is how precision medicine can take out the waste and the cost in the system, particularly the avoidable cost part. Because I think there is a great role in that. But again, I think that if the people in the precision medicine space, for us in the value is how does applying that particular content and platform help the way how we manage patients and populations in a more efficient way is where the dial needs to go. And if that happens, that will shoot up.
Yeah, and then how do we create payment models around that too? So I think it's like the two pieces of it together would enable precision medicine.
Value-based care, why won't we be there yet in 2030? I'd like to ask the panelists to point out the incentives that are most intractable at the moment and the most important. So I'll say the embarrassing thing first, which is the fattest pigs squeal the loudest. The incumbents who benefit with unreasonable returns on their time and money will be the most powerful in general in our system. But there's a lot of regulatory complexity, and there's just a lot of systems nonsense. Like from an outsider's view, the VA and Kaiser look rational because incentives are aligned, but you guys deal every day with not that in the rest of the American economy, and it's enormously important for the whole world economy what Americans flush into healthcare. So that's the question. What is the biggest obstacle to more value-based care?
I think transparency to the end user or the patient. The moment they will get engaged and become a savvy customer, value-based care would happen. Because look at every other industry, travel, banking, anywhere we have activated the end user, we have gotten value out of that system.
So you want to decouple it from employment?
No. What I'm saying is engage the member. Today, when you tell patient this is value-based care, this is the ACO model, their perception is this is a gated model. They think that you're gating my care. They need to know that you're getting a concierge care with higher level of quality, lower level of cost burden, and your experience that is elevated beyond your imagination, which you have never experienced. They think of the HMO time as like somebody who gates my care. That is where you want to engage that consumer, the member, the patient, the human, and get them engaged in their care. They will buy better, they will engage better, they will work with better clinicians, longer time. We have seen that. The retention is much higher when you know that you have a good doctor, right? And that is the key. I feel that is the missing piece that we need to focus on.
And you're right, what's not represented here are the self-insured big companies, right? My husband happens to work for one of the large tech companies down here in the peninsula, and there is this group called the Pacific Business Group on Health, and they are a national organization now. They started out here in the West Coast, and they really, they're working with these big purchasers, the Walmarts of the world, right? The Googles of the world, Apples of the world, because they purchase their own healthcare. They are their own health plans. Now they may have United do the claims and pay the bills, you know, as a medical service third-party administrator, but they are really partnering with the California Quality Committee, which is a large statewide, CQC, which I'm also on that, to how do we drive value, because they understand that, because your employers are subsidizing your health insurance as well, and they don't like seeing you pay the cost. So we're also getting traction from that side, from the large purchasers too.
I think, Ed, you should answer this. You said 30% of your population is value-based care. Is the biggest obstacle
Well, I do think-
the patient misunderstanding of
Well, I think it's at a
of the
point,
value?
I think the understanding and the incentives are not entirely aligned. And I think until that is fixed, I think this will be a conundrum, because, you know, it's, in the Sutter Book of Business, sometimes it says is another patient in our hospital. But in value-based care, that's the last place you want the patient to be, right? And so for some patients, you know, they think more is better. And how to create some get into benefit designs, right? There are things that we want to, that more is not necessarily better. And something patients we want the patients to get, they don't come in to get. You might want to incentivize them to get the mammogram, or to get the vaccine, or come in for just their wellness check. So I think a lot of it's aligning incentives to drive the behavior for them to understand how this is better. Because a lot of patients, they don't understand this. They feel you're taking away choice in the value-based care construct. So a lot of it is that we need to do a better job explaining the value of it, and then construct it so that the right care, the best care for them is the easiest one for them to go. Right now, there's just so much complexity, right? Because I think we started the question, what is value-based care? And fortunately, many of our answers align, but if you ask the patient, I bet it doesn't. And until that is solved, I think the conundrum will continue.
Can I add a piece here, which is it's true, the patients, we need to empower patients to have a bigger vote for what type of care we are getting and paying for. But the reality is, in healthcare today, patients don't have that level of direct power. Their representation is the employer. And so I come back, having worked in digital health, the early adoption from the self-insured employer has really helped elevate certain digital health tools to broader scale adoption. And I think same, large employers, where they put their money, those plans that Pam, you listed, where the employers are putting their money, which plans they're buying and then offering to their employers, that's going to play a big part in which plans really have more enrollment.
Actually, this is sort of a follow-up question. We're always focusing on the consumer, the patient, but my question is with the physician. To what extent is convincing physicians that this is a good deal, the important piece of getting value-based care to happen? And to what extent is there a consensus among physicians here and in the whole country that it is a good idea?
No. Because I think part of it is the incentives may not be aligned. And speaking as a physician, old habits die hard. I'm a primary care physician, and I'll tell you one of the struggles that I have in my team over here is that there's a saying in the work that we try to do, we want to have people practice at the top of your scope, right? So a doctor do doctor work, then a nurse practitioner do that work. However, in that concept for primary care physicians, sometimes it means the work that you do is different. Understand, as a primary care physician, our value is the connection to the patient. So I'm a primary care doc. When I came here in the Valley, I did it to cradle to grave. I ran in a nursery to see babies in the nursery, admitted my own patients, saw them in the nursing home, and etc. But that's an inefficient model to do. So then, some of the work I'm glad to give up, right? And now I'm happy not to kind of cover the emergency room, for instance, and all that from a quality of life perspective. But if you extend it more a little bit, is that there's some what the physician's currently doing can be done by someone else, and is your physician willing to let go? For instance, in hypertension, a condition that if you want any evidence-based approach, that probably is a disease that has one of the most in it. However, our physicians don't want to let go of it for a variety of reasons. Well, that's when I see the patients and I connect with them. Or that is my easier visit in my busy days, and I took that all away. How am I going to get through versus among other reasons? So part of it is the mindset of the clinician, and I do think part of the, and I think there is a part of training our physician workforce team to think in a different way and understanding the role in a value-based contract may be different from the traditional way how they grew up on it. And I think that part of that change journey is something we have to go through. And I think, particularly in a large organization like Sutter, we have the ability to have diversified ways of practicing things. Like, not all of our primary care physicians have to practice in one way, and not all patients probably want that. Some of our patients, they only want to see me, even though I'm only in clinic two days a week. They will wait to see me versus see my physician assistant or my colleague. You know, and I appreciate that, but sometimes it is not the best care for them to wait for my access to happen. So this team-based care from the physician side, how to mold that, how to have patients understand that you're not getting inferior care if you don't see your own primary care physician, and many other factors falls into that. Thank you.
And as I say, that's also why it's important that we also reimburse physicians, not just for that fee-for-service episodic care, right? Because you're right, the old thing, do more, get paid more, right? The more knees I replace, et cetera. And so also having a percentage of the compensation tied to the outcomes and tied to that is also a way to bring people along, because they can see, you know, I'm getting paid for this quality of care. In addition, above of what I am getting paid for my encounters with my patients. I don't know if Imran or Irene has anything to add to that as practicing physicians as well. But I think sometimes it's hard in a salaried position to get down to the people that are actually doing the work. So I think from an independent, you're going to see the dollars a little bit more impactful.
And, yeah, go ahead.
I apologize.
Yeah.
So I think in general, physicians want to do the right thing. I think in today's day, today's marketplace, we are struggling with data fatigue. And so hearing alignment happen, hearing technology processes that build alignment, cleaning up incentives, because I'm an independent physician, I run a multi-specialty group, I see United Healthcare patients, I see Sutter patients. There's a different incentive for United Healthcare patient, there's a different incentive for Sutter patients. Different for Aetna, different for Blue Cross, different for Blue Shield. And my panel on a given day is varied. And so when you're asking your physician, you're sitting them with your physician in that room, a lot of times this is happening and this is not happening. And so we're using AI now to get rid of some of this manual data entry pieces. We're using tools that give us that signal to act on the care that needs to happen in the room, so that we can spend more time caring for the patient and not dealing with the nonsense of data entry and data pulling and data processing, or prescription filling, or coding, or all of this other stuff that interferes with the human-to-human connection. So I love what I'm seeing. Thank you.
And I like what you said, that every clinician is out there to do good for their patient inherently. But one of the things the question that you asked, what's standing between, what are the providers? What is the barriers from the provider side? One of the things I would say is the foundation model, in which it's almost like a pyramid scheme in which everything feeds into the big mothership kind of idea, in which the fee-for-service is really feeding the higher complexity care or specialist care or procedures. In that way, it's harder to break that system and bring it to a value-based system. What I would say is, the more we would empower a primary care physician, the more value-based care would happen. We have to shift, like almost flip this model upside down, and have the primary care physician to be paid, will be not the gate, but are really your concierge consultant in this healthcare journey. And that is where we would make the difference towards that.
Rajan Dalal alum. One player that was not named this evening is the caregiver. By some estimates, there are 50 million Americans who care for the patients without compensation. They care for their parents, their spouses, their siblings. What role do you see for the caregiver playing in the delivery of metrics, outcomes, and so on?
I would share, this is a very, very key question. At least from the employer perspective, I have launched caregiver services, like point solutions that actually helped our employees who were taking care of either, their kids with special needs or parents with, conditions, or their own wife with, or husband with cancer and others. So the caregiver is a very, very important, partner with the physician, and it is part of that, wrap around the patient, the member, the human, and it's a very important component. And employers have invested in that option. I'm gonna pass it on to Pam to kind of see how you're engaging.
Can you explain that a little bit more when you say they've invested in that? Does the caregivers get, what do the caregivers get?
Yeah, so of course caregivers get support for transportation, for example, for time off, child care, ABA services, whatever their needs and gap in care looks like. How do we support that caregiver if they are becoming now the sole earner and the dad or the mom because the spouse is now going through cancer treatment? How do we get food supplies to home? How do we get transportation for kids to go back and forth from? Those are caregiver support things that employers have invested as several point solutions that are out there. I've launched 2 in my large employers. But what you're asking is how does that feed into the value-based care? I'm going to pass it on to.
Yeah, so we are working along that where we have our physicians in the office seeing the patients, and we have the wraparound services, right? So I actually oversee, and I didn't do this in my introduction, I have virtual pharmacists, I have care managers, I have social workers, I have community health advocates, I have health educators, health navigators, patient experience folks. I know I'm forgetting something along there. But one thing that we are doing is, if a patient has a complex need, we have a care manager that's assigned to that person, and they assess all the needs from the social determinants. And we also have community health advocates that are lay people that also reach out with patients, and we help assist them with what are the resources, what does your health plan have as an added benefit? What do we have in your community? And in fact, we are implementing a technology platform that we're going to integrate into our electronic health record, where our care managers, our physicians, the physician MAs and the physician practices, and patients themselves can go on and look on a platform by zip code and can help find resources available to them in their community. But we are seeing more and more health plans having a transportation benefit, having some meals after surgery where they can come. You see respite care things sometimes for people taking care of terminally ill patients. So that's what we try to do. It's very complex. We try to help tease what's available and help connect patients to that. But I don't know, Ed or Con or...
With that, I actually think we should wrap up and thank our speakers so that we can have half an hour of networking time. So thank you very much. And as a token of appreciation, we've got you these folios from MIT, from the COOP, just to say thank you very much. And I have one for each of you. So. We're looking forward to seeing, so half an hour of networking and then volunteers, please stay and help us clean up. And we're looking forward to seeing you at the next event, The True Purpose of Nutrition, on March 20th. Thank you.